Hello and welcome to Chronic Things. Today I'm talking to Jess, a registered dietitian, a nutritionist and an online IBS coach. I really had fun talking to Jess and we tried to keep everything in plain English so it should be quite easy to follow along. We discuss IBS timeframes, that is to say the time frame in which someone might get diagnosed with IBS, the point between symptom onset and actual diagnosis, which tests should be used to identify IBS. We talk about the IBS subtypes such as IBS D, C, and the less known U and M subtypes. And we also talk about what patients have tried before they see Jess, such as the paleo diet, the keto diet, or other methods. As I mentioned, I really enjoyed talking to Jess. It was quite interesting, and I'm hoping you enjoy this episode. I wonder if you could just give a general background about yourself.
Sure. So my name is Jessica Roocroft. I'm a registered dietitian. I'm based in North Vancouver, British Columbia. And I have two little kids, a 3-year-old daughter who's actually going to be 3 tomorrow, and a 5-year-old son, and 2 dogs. And I basically started my profession as a dietitian 10 years ago, but never really honed in on irritable bowel syndrome until I developed it myself. So, that might be a common theme with some professionals sort of niching down into certain topics. Definitely was the case for me. And, but I really truly feel that someone who's walked in the shoes of their patients is ultimately going to have their best interests at heart and just have so much more empathy for the situation that they're in. So I got irritable bowel syndrome after a traumatic event in 2016. And it literally seemed that overnight I just could not digest my food. Like it was a little slice of hell, to be honest. And even as a registered dietitian, with so much knowledge, I still had no idea what step 1 was and step 2 was, because when you first get hit with, some weird changes in bowels, you automatically first think, oh, this is, stress, which I was stressed, or it was diet, or, maybe food poisoning because I had to travel somewhere to became ill. And so many things that just know where to start. And even though my doctor wasn't quite so sure, what I was getting at with the tests that I was requesting as a registered dietitian, I knew, sort of what tests to, ask for and explain my gastrointestinal symptoms, and hopefully it could be guided. But really, my journey through the Canadian medical system was fairly lackluster when it comes to irritable bowel syndrome. And I know that my patients, many of them have had the same journey. So I'm just so happy to, spread all the irritable bowel syndrome knowledge and, resources, and just hope that even just a few people can be helped. Because I really do, if I didn't already have a background in food, nutrition, and health, this would have been a lot more challenging to manage my situation. So hand to heart, so much, empathy for people who are going through this. That it seems like they're on their own sometimes. And yeah, they are definitely not. They just have to find the right care team. And yeah, so that's where I am. So I started my private practice, and I all of a sudden one day started talking about bloating specifically. I wasn't ever aiming to be an irritable bowel syndrome focused practice, but I just automatically started talking about it. And then people started coming to me. And so that's kind of how it started. And I literally don't feel like I work a day in my life. I absolutely love my job. It's very fulfilling indeed. So yeah, so thanks for having me.
Oh, that's good. That's interesting. What was the time frame between you developing IBS and actually realizing that it was IBS?
Okay, that's a good question. So a lot of my clients come to me saying they felt like they always had sort of a sensitive stomach, but it never really bothered them. Some people stay in this sort of, category of mild IBS, and some people stay, some people advance and become more severe. So I might have had just a little bit of, a touch of it, but nothing that interrupted my quality of life or, my tasks or my education. Really just a bit of maybe say gas at the end of the night, or, with certain foods, or, I knew that I couldn't handle large amounts of ice cream, for example, but, nothing that made me think there was anything going on until the day that everything I felt like I was hit by a tidal wave. Something had totally changed. And so the duration of, the sort of mild symptoms was probably since childhood, which a lot of my people definitely echo, which is very interesting. And it actually touches on what I was going to touch on later about irritable bowel syndrome. Typically can change in severity. 1/3 of people stay the same in their severity. 1/3 of people get worse over time, and 1/3 of people stay the same. And there's no rhyme or reason as to why. But there it is. So it's definitely lifelong, somewhat something in the background as a child, but nothing too bad. And then 2016 August, that was when the little bit of a traumatic incident in our family had happened. And after that time, probably I would say it was probably a solid year since symptom onset that I had, brought this issue to my doctor, had the tests, trialed some things, and definitely landed in this sort of management of irritable bowel syndrome to kind of handle my case. So yeah, definitely a solid year of awareness and testing, and then trialing, and then getting even good at managing IBS. And that's from a dietitian's, perspective. Now, if that happened to a regular person, statistically, they say that it takes 10 years for someone to even come to a diagnosis of IBS, and even longer to actually get it well managed, if they ever do, which is very shocking.
Yeah. I mean, I can relate. I developed it as well. So.
Oh, do you?
Yeah. Joy.
You're a tribe.
So, I think before we kind of get into it more, I'll ask the obvious question, just for anyone who's going to listen. Could you just very briefly describe what IBS is for anyone?
Yeah, absolutely. So someone with IBS has to have had their symptoms for longer than 6 months before diagnosis. And the reason for that is, well, it seems obvious to medical professionals, but it may not so much for other people. But we want to make sure that, or doctors want to make sure, doctors are the ones who diagnose, not dietitians. Doctors want to know that this isn't some acute, infection, gastrointestinal parasite, bug, whatever you want to call it, that's just sort of transient and it will go away over time and with treatment. They want to make sure that it's recurring and relapsing, and it's sort of long-standing. So the symptoms have to have lasted for 6 months prior to diagnosis. And a person has to, an adult, so it's different for kids, but an adult has to satisfy the criteria of abdominal pain associated with, and for the last, at least 1 day a week, and for lasting for at least 3 months, someone has to fulfill this criteria. 1 day a week of abdominal pain associated with a change in stool form. So your poops are getting more hard or more mushy. A change in stool frequency, meaning your stools are becoming less frequent or way too frequent in terms of diarrhea versus constipation. And that the pain is related to defecation, meaning some people, feel better after they have a bowel movement. Most people do. Very rarely I hear people feel worse, and usually that would point to something else. But that's the actual Rome 4 criteria that they updated in 2006. Before it was up and discomfort associated with, et cetera, but they reduced they cut out the word discomfort because I believe they were trying to make it more so sort of less ambiguous, because someone's idea of comfort might vary. They see it as more clear. I still have people who don't have necessarily an exact cookie cutter diagnosis, sort of constellation of symptoms, or match that criteria exactly, rather, and still do respond to dietary interventions for IBS. So, it's not a perfect science, in other words, but that's a diagnostic criteria. As long as someone has had that criteria filled for the last 3 months, symptom onset for more than 6 months before, and then they meet that criteria. So abdominal pain at least 1 day a week associated with defecation, change in stool form, change in stool frequency. And really importantly, before that is the diagnosis that is laid down for someone or given to someone, an adult really needs to be screened properly. And it's very interesting how few patients are actually given the proper information before they go in for their tests. So one of the tests that absolutely, hands down, needs to be done before an IBS diagnosis is given is a test for celiac disease. It's a blood test. It's called the TTG IgA. So it tests the level of an antibody to make sure you have enough, so that it gives a accurate reading. And it tests the TTG, it's tissue transglutaminase. And in order for all this to work out and to screen for celiac disease, someone actually has to be eating gluten at a certain amount for weeks leading up to this test. Otherwise, the test is null and void. It could be, the risk of false negative is super high if someone hasn't been eating a prescribed amount of gluten before this test. So many people just get the requisition, screen for TTG, and they've already cut out gluten from their diet because most people have already been struggling for so long that they're trying to find every way that works. They cut out things before they get tested properly, and they find out after that test is null and void. Even if they had celiac disease, they just didn't have enough gluten on board, and they'd have to go back again. So it's quite defeating. So celiac disease, number one, that needs to be screened out. And the other tests rely on sort of your doctor's opinion and your sort of constellation of symptoms, and if you have any other red flag features. So things that need to be ruled out as well are things like inflammatory bowel disease, which can be done by a blood test that looks for inflammation, either CRP, or they can look in your stool to see if there's any inflammation in your stool. That's called fecal calprotectin. So they'll screen for that, and as well as any alarm features, those red flag features, such things as fever, weight loss, you have family disease, you have a first degree relative with celiac disease, you have anemia, you have persistent daily watery diarrhea. So there's a few more, and these really need to be factored in so the doctor can make a proper informed decision of what other tests to do, scopes, etc. But really, there's a really good paper, I think it was out in 2019, and they were saying that really the major two are screen for celiac disease, rule out IBD, and that if that person, the adult, fits that criteria, that Roan 4 criteria, that should be sufficient enough for a diagnosis of IBS. Again, as long as their opinion doesn't, warrant, their information that they have doesn't warrant further testing, based on that, what I just said, and a few other things that they would consider. So yeah, that is a long-winded answer, but that's what IBS is.
Okay. Yeah, that's interesting, especially the whole diagnostic criteria behind IBS, because I certainly know that I did not go through that exactly. Have you? So you treat patients with IBS?
I help with medical nutrition therapy. Yeah.
Okay. Yes. So have you noticed, or are there any symptoms that appear to be, say, the most common between patients with or individuals with IBS that you've treated?
For sure. So there's further subcategories of IBS, and people really, not only just to get a diagnosis of IBS, that's huge, first of all. And second of all, a lot of people are told, oh, it's probably just a little IBS, which is really invalidating and defeating. and kind of makes other, diagnoses, and they don't really buy it if someone is told they have a little IBS. So to really help understand the symptoms involved in IBS, it's really great to take a closer look of the subtypes of IBS, which someone should really be not only diagnosed with IBS, but diagnosed with their subtype, because this drives, especially in my line of work, the medical nutrition therapy for them. So the symptoms are oftentimes they kind of group together. So anyways, so there's 4 subtypes. There's diarrhea predominant IBS, or IBS with diarrhea, constipation predominant IBS, mixed predominant IBS, meaning you go back and forth between constipation and diarrhea, and IBS U, which means that you don't really fall into IBS D, M, or C, and you're just kind of grouped in the U's. And there's not a lot of research on IBS M's or IBS U's, unfortunately. Mainly the research is done with IBS C and D. And so the symptoms for IBS D, obviously diarrhea. So diarrhea is, so those beautiful Bristol stool charts that we love looking at as medical professionals, Bristol stool chart number, the stool number 5, 6, and 7, that person has to be experiencing 5, 6s, and 7s more than 25% of the time of their abnormal bowel movements, and less than 25% of the time the Bristol type 1s and 2s, which are those hard pebble, rabbit poops, or the hard pebble rabbit poops shoved together into a really lumpy log that's difficult to pass. So they have to be less than 25% of the time, those 1s or 2s. Then they could fit the subtype of IBS D. And then IBS C is that, but the opposite. More than 25% of the time, they're Bristol type 1 or 2. And then less than 25% of the time, they're Bristol 5, 6, 7. And then mixed is more than 25% of the time, they have both ends of the spectrum in terms of hard stools and loose stools. And then IU is, again, they don't fit under those categories. So IBS Ds, they usually deal with, obviously, diarrhea, urgency, a lot of nausea, I find. And whereas constipation predominant folks obviously deal with constipation, a lot more abdominal pain, I found, because obviously when you're constipated and you have, increased visceral hypersensitivity, that's a hallmark of IBS. It really hurts to be constipated. And I also find those people have a lot more instances of reflux and heartburn, because it kind of makes sense. It's not a very, eloquent way of saying it, but when things are upset in your gut, lower down, typically I see things higher up in the gut also kind of come apart as well. So if things aren't moving down below, I do see a lot of nausea and early satiety, and people just feel full after eating relatively little, and they just have a feeling of incomplete evacuation, where they feel like more poop needs to come out whenever they have a bowel movement. So the symptoms with IBS D and C can be similar. It can be any mixed bag, honestly, though. I feel like IBS is like an item, it's like an outfit. Everyone wears it differently, and everyone's got a different constellation of symptoms. But yeah, usually bloating, abdominal pain, constipation, diarrhea, or alternating between constipation and diarrhea, reflux or heartburn, incomplete evacuation, early satiety, and then a couple other things like brain fog and low energy. They're, just in a flare-up situation, it's quite fatiguing. But that also all these symptoms can sort of blur to other gastrointestinal illnesses or other illnesses in general. And that's why it's so important to just go and get those tests to be sure. There's just so many nasty things that it could be, as opposed to IBS, which there's no organic cause. At this point, they haven't found one yet, at least. Okay. So yeah, symptoms very different. Most commonly, though, it's altered bowel habits, abdominal pain, and bloating, and then again, depending on what subtype they are, the rest kind of fall where they lie, and in various combinations, I would say. But interestingly, there's a third of people across the IBS subgroup. So the Ds, the Ms, and the Cs usually are about equal parts, a third, and with a fewer amount of people being in the IBS U category.
Okay. And so when you're looking or when you're working with these patients, does IBS seem to sort of come hand in hand with other diseases or comorbidities or sort of health issues that people don't commonly think of as related to IBS that you have seen?
Yeah, I mean, there's a lot of issues that come hand in hand with IBS that, well, one that is, it's not quite sure if it's a common misdiagnosis or a comorbidity, for example, is endometriosis. So we have evidence that tells us that people with endometriosis and IBS respond even better to certain dietary interventions than people with just IBS alone. So that's one that is kind of like either or. We don't know if it's a comorbidity or just it's grossly misdiagnosed, because there's so many overlying symptoms, bloating, abdominal pain, changes in stool, so that's one that's very important for, I think, the women's health in general is just needs some work when it comes to awareness of the most, it's 10% of the female population has endometriosis. I was completely unaware I had endometriosis up until this December. I actually had a total hysterectomy this December, had endometriosis and adenomyosis, apparently. I had no idea. All I knew is I was suffering every month, and I kind of just seemed, it felt like I was being just brushed off as, oh yeah, this is normal, it's monthly. It's like, actually, no, that was completely unnormal. That's no. So yeah, so endometriosis, overlapping comorbidity or misdiagnosis, we don't know. Other things are anxiety, eating disorders, and other mental health issues, or those are the ones that stand out, that come to mind in particular for me.
Okay, and so people have been diagnosed with IBS, and they come and see you. What kind of things have you found that they try in terms of trying to deal with the IBS before they actually come and see you?
Yeah, what have they not tried is the bigger question. And again, hand to heart, I feel for them, because I was just as confused. Here I was with like this registered dietitian, stamp of approval, diet and lifestyle and exercising and, work-life balance and all the stuff and things. And then just all of a sudden it's like the carpet got pulled out from underneath my feet. And you probably might relate with your diagnosis, but I'd love to hear more about that as well. It's just, sorry, what was the question? I went on a tangent there.
Yeah, no worries. So what things have patients tried?
Oh yes, sorry, what did they try? Yeah, and again, that's where I went on that tangent, is you just don't know what to do, because you may be brushed off by, a lot of people are brushed off by their family doctors, and a lot of people just don't go to their doctors because they're too embarrassed to talk about their bowel movements, etc. But I see people eliminate gluten. Again, the worst thing you could do is eliminate gluten, because even though you may feel a little bit better, because and we'll get into there's gluten and there's FODMAP often showing up in the same foods. So if we eliminate gluten, then sometimes you feel a little bit better, but not all the way better. And it makes someone fear gluten. And then they are rendering themselves basically at a worse off state to be clearly screened for celiac disease. People eliminate dairy, either lactose or dairy protein. You've heard of A2 milk. There's beta caseins that they can now sort of separate in milk, and some people tolerate A2 milk better, but that might help, but not all the way help. Again, they'll cut out sugar, they'll cut out carbs, or they'll go paleo, or they'll do keto. And usually these things are very clear as to whether they help or harm. So for someone with IBS D, if someone goes keto, it's usually a disaster, because a lot of people with IBS D have a real big problem with handling certain amounts of fat in the diet. And if we're going keto, and say a quarter of people with IBS D also have something called bile acid malabsorption, that's again disastrous. And then same with IBS C, if they cut out certain things that are, nice, high in fiber, and they just get more backed up. That's usually not so good. So yeah, I've seen it all. Lots of diets, lots of things cut out.
Mm-hmm.
They go to naturopaths and naturopathic doctors are amazing. They're lovely. They do great things. I see one for bone therapy myself. But a lot of them peddle antibody testing for food sensitivities, and then I'll get people come to me with a laundry list of foods, and they're like, I can eat air. That apparently this is what I have to eat in order to feel better, and I'm so confused, and they'll be so restricted. And maybe they'll feel better because they're starving and they're actually not eating anything. So that does help symptoms if you're starving, because there's no food to cause you issues. So yeah, unfortunately, and I say that, in jest, but that's not the good thing to do. But yeah, I've seen a lot of things.
Yeah. And this question is a bit of a tangent, but
No, tangents are great.
it's also so I wonder, for people with IBS, do you see higher levels of inflammation in general in the body? I'm not sure. I appreciate probably you have to send them off for some sort of blood test. I'm just curious if you have sort of seen anything like that.
Yeah, so I wouldn't say I see it, but there is some research coming out that some people with irritable bowel syndrome may be experiencing some low-grade inflammation, and that might be contributing to some things like the fatigue and brain fog. But that is really, it's not really tested in particular for IBS. If it was at a level, I don't know if it would be detected by, something like a CRP or the fecal calprotectin. But there is some interesting research coming out. I think there's one, and it's a rat study. Unfortunately, I don't have clear research for humans yet. I believe there are research. They researched basically beta fructan, which is a type of FODMAP, which is a type of a small sort of group of fermentable carbohydrates that are found in some common healthy foods like onion, like garlic, like wheat breads, etc. And they've actually found that some patients with inflammatory bowel disease also increase sort of an immune sort of an inflammatory response to their gut bugs, their microbiota coming to contact with beta fructans. And then I think they replicated that in just mice studies. But if that is the case with someone with IBD, I don't see why someone with IBS might not be able to have a low-grade inflammatory response as well. I do think they're doing a lot more research on that. The things, I don't like to say the word leaky gut, but we do have, a lot of research coming out that, when our gastrointestinal system is just up in arms, that we are possibly increasing the gaps in between our cells, so loosening those junctions which are supposed to be tight and supposed to keep out things from our external environment into our internal environment, and that's possibly causing some cascade of inflammation. So yeah, lots of interesting stuff, but nothing that really guides medical nutrition therapy beyond what are kind of the mainstays of IBS management at this point.
Okay. Yeah, no, I was just sort of curious on the whole sort of inflammation front. I wonder, so what do you think, and I imagine this the answer to this question probably varies depending on your IBS subtype, but is there any sort of protocol or any treatment that you find is particularly sort of effective for someone with IBS in your experience?
It really depends on their subtype. I found that's the biggest variable to nail down and be clear on. Interestingly, a lot of people who I counsel, I'll pull up the Bristol stool chart and I'll ask them to point to what their stools usually look like. And someone's idea of diarrhea and constipation, it varies wildly. So, it depends, first of all, on are they, truly IBS-D, or are they truly IBS-C or M, etc.? So getting clear on, what their subtype is the most amazing way for someone to actually find some more specific advice if they don't see a registered dietitian who's trained with IBS, sort of the practice of IBS. So if it's, say, for example, diarrhea predominant IBS, which is definitely my thing, I do believe there are fairly clear starting steps with that, and actually created an entire IBS D program that uses the steps that manage my severe IBS D. So one of the things would be, for example, dealing with the abdominal pain and bloating, etc. So that would be helped by the low FODMAP diet, for example. Why? Well, FODMAPs, a lot of them are great water magnets. They travel down our bowels relatively unabsorbed and undigested. So that increases the osmotic load in the gut. Basically, they pull water into the bowel as they go along, and then they get into contact with our good gut bugs and they get fermented. And then this sort of can, create that gas making part that is sort of the reason behind the bloating and discomfort. And then it kind of ends up in, the altered gut motility. So FODMAPs make someone with IBS-D's gut move way too fast. If you think of everyone with IBS-D is driving a car, I'm driving an IBS-D car. If I put FODMAPs in my gas tank, the default reaction of my car as an IBS-D car is to slam on the gas pedal. It goes way too fast. And then the opposite is true for someone driving an IBS-C car. Their gut's reaction, for various reasons, one of them being, maybe a certain type of gut bug be overgrowing, producing methane gas, which is quite constipating when they hit when their good gut bugs ferment FODMAPs. Their car's default reaction is to slam on the brakes and go way too slow because methane gas is constipating. That's one theory, but like in general, when they have FODMAPs, that's gut mode. FODMAPs, they're on this sort of roller coaster of hell that goes fast, slow, fast, slow. They kind of bunny hop, if you imagine that. So for IBS-D, not putting so many FODMAPs in the gas tank, and helping tap the brakes further on an overly speedy gut, definitely would be a low FODMAP soluble fiber therapy plan. And as well, watching roughage, because roughage or insoluble fiber also does a great job of making really bulky stools, but they don't hang on to water. So they are a lot more soft. And that's something that someone with IBS-D doesn't need. Thank you very much. So they really do benefit from soluble fiber, low FODMAP soluble fiber therapy, either partially hydrolyzed guar gum or Acacia Senegal. I don't recommend psyllium, even though it is a soluble fiber. It's moderately fermentable, so it's moderately kind of high FODMAP. I find a lot of my clients don't tolerate it very well. For some people who do, great. For some who don't, might be time to switch to a low FODMAP soluble fiber therapy, because that can help gel stools, make them firmer, have more complete evacuations, less loose stools, slow down the gut, and kind of help give your gut just a hot second to slow down and give your body a chance to feel a little bit more normalized in terms of gut speed, as well as low FODMAP diet and watching roughage. So yeah, those are the sort of steps that I've done for IBS-D that I found very, very effective.
I guess one of the other questions that I have, I'm not entirely, the research on this, not necessarily around IBS, but the research on sort of like the gut microbiome seems to be sort of expanding a lot at the moment, as near as I can tell. That is to say, if you kind of move out of the domain of IBS and just look at the sort of some of the studies in general, I guess I wonder if there's a major role that kind of your gut bacteria play in IBS. Is it sort of the, you mentioned that gut bacteria might be sort of associated with sort of FODMAPs to some extent?
Yeah. So, I mean, everyone's, gut microbiota is different. And then I follow a really amazing dietitian in the GI space, and she wrote a book called Regular. You should check it out. It's really great. Tamara, I don't want to butcher her last name, but her first name is Tamara something, Ducker-Froman or something. Anyway, she made a book called Regular, and one of the chapters she's talking about in the constipation section, she was talking about the kind of the thought that, if someone is overgrowing a certain bacteria called archaea, those are a type of bacteria that are, they produce methane gas when they ferment FODMAPs. So if someone is overgrowing, archaea, and their, good gut bugs can't, sort of offset how much of the archaea are there, and thus there is an overproduction of methane gas, which is very constipating. Then she said something really interesting, something about then once in a while, perhaps someone's sort of gut bugs, there's like a garden, and once in a while you have to weed it. So propose the idea that sometimes when someone's overgrowing a certain type of bacteria, that might be, constipating in the case of archaea, or maybe diarrhea in the case of, potentially, gut bugs that produce, the hydrogen gas. So that's like usually more associated with the diarrhea, I believe. Then once in a while, sort of antibiotic therapy might be beneficial, and various, types and combinations, depending on if the problem is constipation or diarrhea or a mix. In order to sort of weed out certain ones that might have overgrown, and it's kind of sort of disrupting the status quo of your gut. And there's another one that, if we're talking about, the role of the gut microbiota, I mean, I think the research is just exploding. There's no way I can actually keep up with it. But if someone has a direct insult to their gut, say like severe food poisoning or gastrointestinal illness, that could definitely set the stage for irritable bowel syndrome. 1 in 10 people who have food poisoning or traveler's diarrhea or gastrointestinal infections of some sort wind up developing irritable bowel syndrome. And it's usually the diarrhea predominant ones. And interestingly, again, people with different subtypes of IBS can change subtypes. So perhaps, when someone was once maybe having trouble with diarrhea, perhaps at some point they can actually turn, constipation predominant. Rarely we see constipation predominant folks go to diarrhea predominant. But perhaps there is maybe some major shifts, some of these events that are affecting, one's chances of developing IBS, for example. But yeah, they're usually quite major. It's really tough to augment your gut microbiota on a regular basis. Even if you take a probiotic, the second you stop taking that probiotic, think of a probiotic as like a traveler in your gut. It doesn't stick around. It's gone. It's got its suitcase and it's out. So if we stop supplementing with probiotic, your gut microbiota basically goes back to its baseline. So it's quite tricky to change your gut microbiota unless, again, there's like these sort of major shifts or major events, or something has totally disrupted it. Prolonged antibiotic use, or, certain medications that tend to not really jive well with your gut, such as like non-steroidal anti-inflammatories. I'm not sure what they actually do to gut microbiota, but I know that they're, definitely irritating to the gastrointestinal system. And, what does that mean for gut microbiota, etc. There are some gut bugs that, and I say gut bugs, when I mean gut bugs, there's bacteria, fungi, viruses that are all part of your natural and healthy, gut microbiome. The microbiota in it are the bacteria, but the microbiome is it's got all the players, the viruses, the healthy viruses, the not so good ones, the fungi, etc. Well, the not so good ones are not supposed to be there, but you know what I mean. So when we have, this sort of a sort of person who doesn't have any digestive issues, they may have, more or less of a certain, fungi, but that doesn't necessarily mean they are more likely to get IBS. Like there's a lot of naturopaths that are sort of pushing this idea of like candida and candida overgrowth, but that's pretty rare. Usually people with only severely immunocompromised, systems have this sort of issue. And there'll be a lot of people who are peddling a bunch of expensive supplements to take down, candida, and like sugar-free diets, which are silly because sugar is absorbed much higher up in your intestine, not in your large intestine where these are, or lower down in your GI tract where these are proposed to overgrow. So that's kind of like, it's sort of a little bit of my, and this is a nutshell, because this would be like 50 years of podcasts to talk about the gut microbiota and microbiome. And there are some, I'll just end this sort of rant by saying there are specific bacteria that are shown to be likely helpful to someone with IBS, and these bacteria or combinations of bacteria, and they're or some of them are a yeast strains, like Florastor is a yeast strain. These are all listed under a really lovely website called Probiotic Chart. There's one in Canada, it's called probioticchart.ca, and then you can just look at which probiotic strains and doses have evidence for IBS, or evidence for, say, functional constipation, or evidence for, there's a whole bunch of things, and someone can look and see which one might match their needs the most. So for probiotic to be effective, needs to be the right strain, the right dose, and given to the right person for the right reason. So that's my microbiota rant in a nutshell.
Yeah.
Are they helpful? Are they harmful? What really depends on the person, what their scenario is. Like some people need antibiotics, some people need probiotics, some people need neither. So
it's interesting because I've noticed that a lot of probiotics do not include the strain. As near as I can tell, the actual sort of bacterial strain, because if I remember correctly, for bacteria, you have the name, and then you have usually a sort of a number or a sort of alphanumeric kind of lettering that will indicate which bacteria exactly are within the probiotic. And I certainly, because I spent some time looking for probiotics for myself, and I've noticed that there are certainly some of them that will say it has a certain bacteria, but you're not quite sure exactly which bacteria they actually have as well. So one of the other things I wanted to ask you is, do you find that for people with IBS that the gut motility is sort of affected? I suppose it is for constipation anyway. Is it quite sort of common across individuals?
You mean like gut motility in general? Is it like a problem amongst IBS? Yeah. So one of the criteria that are, changes in stool consistency, well, this could be, poops getting too hard because they're staying in the gut too long. So the longer your poop stays in your rectum, the drier it gets. So someone with constipation predominant IBS might have slow gut motility, or they, have just a tough time, evacuating that sort of dried out stool. And that can be quite problematic. And again, why someone has slow gut motility, that could range from, overlapping pelvic floor issue, or just slow transit time, or, certain lacks of dietary components like, insoluble fiber or water that can exacerbate the condition. But yeah, altered gut motility is usually one of those things that is a problem with people with IBS for sure, except possibly for the IBS-Us, which don't necessarily seem to have an issue with constipation or diarrhea or the mixture of back and forth. They're just kind of experiencing abdominal pain with, bloating, or, some other gas, or just other sort of symptoms. But yeah, gut motility, it does play a huge role, because, as much as I'm trying to slow my speedy gut down, someone else might be trying to speed their very sluggish gut up in order to manage our symptoms. So it, again, is very individual. And to touch on that question before about what your, other steps for people with like different types of IBS. And I mentioned my steps for IBS D. I actually glossed over IBS C, if you want me to go over them now.
Yeah, sure. If you have time, then sure.
Yeah, so IBS C, it depends on, again, those overarching sort of overlapping potential things that are going on. But if there's no pelvic floor dysfunction and, slow, gut motility or slow transit time or, opioid induced or what have you, like taking a bunch of pain medications that slowed it down, etc. If it's sort of like the classic constipation phenomenon IBS, well, first of all, low FODMAP, because again, that sort of mechanism that we think might be happening when we're overgrowing methanogens, they're running into FODMAPs, they're creating methane gas, they're slowing down the gut, which is just wreaking havoc on everything, speeding the gut up. So some people tolerate insoluble fiber or roughage well when they're constipated, predominant IBS, and some people really don't. So that would be a sort of a judgment call on the dietitian and the patient. And then definitely putting something in their system that can help speed up that gut motility. So some people rely on, relatively, moderate to high doses of magnesium at night. Magnesium citrate is usually the most tolerated and least bloating. Magnesium oxide is usually more bloating. And a dose of about 450 milligrams usually helps create more of an easier time pooping the next morning. Or if someone is, full of stool and really is struggling, we want to make sure we reduce the risk of obstruction. And in that case, that might be, they might need to resort to, PEG powder like Restorelax or enemas or etc. So those are the other things. So get the bowels moving and reduce that bloating. So either way to do it, it's very individual and a lot more tricky with IBS C. I find the IBS D steps are a lot clearer and a lot more effective most of the time compared to IBS C or M's for that matter.
Okay. So so before we sort of draw this to a close, let me ask you, so for individuals who are interested, sort of where can they find you? Like sort of any social media, which sort of websites?
Yeah, so I am jessnourishes.com. So Jess nourishes, just like nourishes your belly. So jessnourishes.com or Jess_nourishes on Instagram. And I do have a nice little library of free mini guides that I warmly welcome anyone who's struggling with irritable bowel syndrome to download for free from my website. It also subscribes you to my monthly newsletter, which I'm very non-spammy. So I think there's maybe 2 or 3 emails in my email marketing milieu at this point. So don't be afraid. What you're going to get is probably about 16 pages of IBS advice for your specific subtype. So IBS D, M, U, or C. And yes, for residents of Vancouver, British Columbia, or anywhere in BC, I have that diarrhea predominant IBS program. And one day I'm hoping to launch a self-study IBS D course that hopefully anyone in the globe can access. That obviously won't be run live and in person and individualized by me because I'm registered in British Columbia and I can't take clients out of province, but hopefully that will be enough of a kickstart to help someone struggling with IBS D get started. But yes, in the meantime, those IBS subtype mini guides are on my website, jessnourishes.com. I believe it's /self-help resources. So yes, warmly welcome anyone to grab one of those. It contains, all the tips for your certain subtype of IBS. I think it's like a 3-day meal plan for each, shopping list, low FODMAP swaps, for example. It's really chock-a-block full of really useful advice, and also put some of the common myths about IBS in terms of testing and diagnosis to bed, and also reminds us of those red flags and anything else that needs to be brought forth to your doctor, and a list of other things that it could be besides IBS. So yeah, thank you for having me.
No worries. Thank you. This was fun. I enjoyed it. You are a good source of knowledge, I must say.
Thanks. Hope it wasn't too much knowledge.
No.